Welcome to the second webinar in our fall series called Dermatology and Celiac Disease. Did gluten cause this rash? Hosted by the Celiac Research Program at Harvard Medical School and National Celiac Association. I'm Lee Graham, Executive Director of the National Celiac Association, serving the gluten-free community since 1993. Food pantries have been telling us that the demand for gluten-free food is 2 to 3 times more than for gluten-free families than ever before. And we've heard stories about moms and dads skipping meals so their kids with celiac disease can eat gluten-free. The launch of NCA's Feeding Gluten-Free initiative in response to this need has been tremendous. Up to now, we have shipped over $850,000 worth of gluten-free food to food pantries in 31 states, serving over 250,000 children and adults. Despite this food we continue to deliver, there are so many more families who need help. Please consider a generous donation to this important program at nationalceliac.org, and thank you. For today, you are welcome to ask general questions through the Q&A feature, which is located on the bottom right corner of your Zoom screen. If you're still struggling to connect with us, tech support is available if needed at digitalmedia@partners.org or telephone 857-282-6470. Also, this session is being recorded and will be available for viewing on NCA's website, nationalceliac.org. I'm honored to introduce today's moderator, Dr. Alessio Fasano, a world-renowned pediatric gastroenterologist, research scientist, and entrepreneur. Dr. Fasano directs the Center for Celiac Research and Treatment at the Massachusetts General Hospital for Children. He's also Division Chief of Pediatric Gastroenterology and Nutrition and Director of the Mucosal Immunology and Biology Research Center at the Massachusetts Children's Hospital. A professor of pediatrics at Harvard Medical School and professor of nutrition at the Harvard T.H. Chan School of Public Health. Dr. Fasano is author of Gluten Freedom, a book for general readers about celiac disease, gluten-related disorders, and the gluten-free diet. He is co-author of Gut Feelings, The Microbiome and Our Health, published in March 2021 by the MIT Press. From personal experience, I am happy to share that he is an exceptionally brilliant physician, all while being a warm, caring, and nurturing human being. Welcome, Dr. Fasano.
Thank you, Lee, for this wonderful introduction. Very kind of you. And thank you, the NCA, to partner with us for this webinar series. Today, we will talk about celiac disease and dermatological conditions. I want to just make a quick technical announcement. We accept questions, through the question and answer, feature that is on the bottom right hand of your webinar page. So if you have any questions, please put your question in there. We're going to screen them and try to address as many questions as possible. If you have a technical question with our webinar, you can call this number, 857-282-6470. Again, for the question, as Lee was mentioning, we would like to have general questions and not just specific your clinical situation to make sure that this is something that is pertinent to the entire audience. And again, this can be visited again because this session has been recorded. Now, without any further ado, let me introduce our first speaker, Dr. Sophie Delano. She's an instructor of dermatology at Harvard Medical School at Boston Children's Hospital. She graduated from Dartmouth College and received a Master's in Public Policy from the Kennedy School of Government. She attended the University of Massachusetts Medical School for Dermatology Residency. She completed her Pediatric Dermatology Fellowship at Boston Children's, where she serves as Director of Quality Improvement and Community Access. She has a particular interest in conditions affecting both the skin and gastrointestinal system, such as inflammatory bowel disease and celiac disease. So Dr. Sophie will talk about a topic, recognizing and treating cutaneous symptoms of pediatric celiac disease. So without any further ado, Dr. Sophie, the floor is yours.
Great. Thank you so much, Dr. Delano, and thank you everyone for having me. I'm very excited to talk. Today, as is mentioned, I do see a lot of patients who are dealing with both skin concerns and gastrointestinal diseases like celiac disease. So I'm going to start us off today in just talking about some of the general signs that you see on the skin with celiac disease, how it's diagnosed, how it's treated, what are some of the mimickers, the diseases that may look like celiac disease that can come up. I'll also start to introduce the topic of what other conditions people who are experiencing celiac disease may also have, may also be a little bit more predisposed to dermatological conditions, something to keep in mind. And Channi will follow up with a second talk, and she'll really dive down more into those conditions. To start off with my disclosures, I have no relevant financial or industry relationships. I am going to be talking about off-label use of some medications. So all the medications I mentioned are not necessarily have specific FDA approval to treat these conditions, but that's often the case, particularly in pediatric dermatology. Also, as I'm coming at this from a clinician standpoint, and we share photos of the different skin manifestations, photos that are going to be showing, skin that's actively involved with rashes, maybe different body surface areas, and folks are not used to seeing over Zoom. So it's just something, to be of note that they may be what some consider more graphic photos, more graphic clinical photos there. These aren't photos of particular patients. These are photos that are from web libraries of these conditions. So overall, again, my goals of my talk are to show the different skin findings that one can have with celiac disease, talk about the mimickers, the things, we might have difficulty deciding between one or the other, and also how we can diagnose celiac skin manifestations more conclusively with a biopsy. We'll talk about the different treatment options for the skin involvement, and then also, again, introduce those skin conditions that can be associated with celiac disease. So celiac disease on the skin is known as Dermatitis Herpetiformis, or in dermatology, we always like to give multiple names to conditions during disease. This was actually the first condition that was diagnosed and described by an American dermatologist, Dr. During, I believe, down in Johns Hopkins. And in dermatology, hundreds of years ago, a lot of the start of our specialty was from looking at skin conditions from bacteria and viruses. So that's where you see the misnomer Dermatitis Herpetiformis coming from, in that when we see celiac disease on the skin, we see Dermatitis Herpetiformis, it can look very similar to what we see with a herpes infection. It can look like small blisters that can be very uncomfortable. But again, this is basically just based on the visual appearance of the condition. And so other than that appearance of small blisters, it really has no relationship to the herpes virus at all. Just getting that out of the way to start. So what do we see in celiac disease on the skin? DH. What we see is intensely itchy, or sometimes burning, small blisters. In dermatology, we call them vesicles. So they're fluid-filled bumps in the skin. That's what we consider the most typical form of DH. Dermatitis herpetiformis can also appear to be like hives. Sometimes it can appear to be just like a red rash, or maybe areas where the blister has popped, and so there's just an erosion on the skin now, sort of like a scab that can be there. It's intensely itchy. These aren't areas of a lot of movement. The blisters aren't that strong that they remain intact for long periods of time. And DH is considered, we look at it both of how it appears on the skin and also where on the skin it's appearing. So we are looking for bilateral extensor surfaces. So on both sides of the body, pretty symmetric. And by extensor, I mean things like the back of the elbow, the fronts of the knees. We can also see it on the buttocks. Sometimes we can see it on the scalp and the neck. Typically, the face and the groin are not as actively involved. Patients can sometimes have gastrointestinal symptoms with their skin rash. But this is the minority of patients. Only about 16 to 20% will have both skin rash and active GI symptoms at the same time. If you were to do more in-depth investigation, imaging, and gastrointestinal biopsy of patients, you'll see that about 90% of patients who are presenting with active skin involvement do also have active GI involvement, whether or not it's gotten to the point of being so active as to cause symptoms. DH is more common in adulthood, but we can see it in young children as well. So now I'm going to show you some pictures. So here's where the clinical photos start to come in. So here again, we're looking at the extensor surfaces of the knees, the fronts of the knees. Here in this picture, you can see again those small blisters or vesicles, as we call them in dermatology, fluid filled. They're not like pustules that would be more cloudy and yellow. But here on the right, we have more, you might not see the intact blisters just because it's been so intensely itchy. You just see the scabbed over healed areas on the background of this larger sort of red-brown rash that you can see. Here's another picture where it shows in more of a healing state of an outbreak, where again, you don't see the little blisters, but you more see the color changes that can happen afterwards. We call this post-inflammatory hyperpigmentation or darkening of the skin after you have a rash. And this is something that can be pretty common for a lot of different inflammatory conditions, but particularly for DH. One of the questions that someone had submitted prior to today's talk was a very good one, asking to show photographs of celiac disease on the skin in darker skin types, particularly African American types. And unfortunately, I couldn't actually find any real good ones to present today. We do think of it more, dermatitis herpetiformis, as more being a condition of lighter skin, Caucasian ethnicity patients. But that's, I can say that, but it still doesn't excuse that in dermatology, we have a long way to go into showing better representation of skin of color, because things look different on skin of color. Darker skin types, a lot of what we're trained on in looking at Caucasian skin and like the redness that you're seeing here and the rashes. In darker skin types, that's going to look darker. That's going to look a darker brown. So it may not appear to a clinician as being bright red. I base it, it's one thing I always ask my patients of color, how does this appear to you? And a patient knows their own skin. So someone can say, okay, this is red. This is where my skin is getting red. And so I think that's also an important part. We're going to talk a little bit through this talk about how you can advocate for yourself in dealing with a dermatologist and, sort of trying to navigate this world of, okay, is my celiac causing this skin rash or this other one, and how do we treat it? But to definitely try to work with a dermatologist and let them know if you feel it's something different in your skin. Here we can see on the buttocks, again, some of those eroded papules and the erythema surrounding it, so still pretty active there. Sometimes DH can also present on the palms and soles, which are some of the thickest skins on our body, not as these blisters, but as small, almost bruises. It's likely the same process is going on here on these thicker areas of skin, but they're just not able to form the blisters as you were able to, like on the back of the knees or the back of the elbows there, or the buttocks, as before. And again, so these will be bruises. When you press on them, the color was going to stay there, and so it's not going to fade away or blanch. So obviously, as you can see, their DH can be on a variety of different surfaces on the body. And so it's always important to think about, okay, is this DH, or could this be another condition that it might be good to try to differentiate between the two, because a lot of these different conditions I'm going to talk here have different treatment options and things to think about. So one of the most common mimickers that we can think of that's also a very itchy rash that can come up on different body surface areas is atopic dermatitis, or your standard eczema. Eczema does tend to appear somewhat earlier in life than DH and can often be associated with a history of other types of sensitivities that one can have, like asthma or seasonal allergies. Atopic dermatitis eczema makes up a huge percentage of my caseload as a pediatric dermatologist. And it might be that I could possibly be underdiagnosing some cases of DH just because, I'm looking out for what I see. And, in medicine, sometimes we talk about thinking about zebras, things that are really unusual, and I'm missing the zebra of DH and I'm seeing the horses of atopic dermatitis. Atopic dermatitis does typically tend to improve with topical steroids. And that is one of the big differentiators between it and DH, that often I can get it better with strong enough topical steroids. Atopic dermatitis also is in slightly different locations, whereas we're talking on the backs of the elbow, the front of the knees for DH. Eczema likes to be on the inside of the elbow and on the back of the knees, so in the opposite direction on those joints as DH. Another thing I always think about when a patient comes in to me with, intense itch is I think about scabies. Scabies will sometimes have little small blisters like DH, and you can often see small little lines on the skin where the mite is burrowing into the skin. Typically, hands, feet, and groin are pretty common for scabies. And often you may get a history of an exposure or a similarly affected household member who also has scabies. If you have allergies to something you're coming into contact with in the environment and you're getting allergic contact dermatitis, you could also have very itchy rashes in different parts of your body. These are often more limited to what part of the body is getting exposed, but is another thing that we always think about with DH. DH likes to come up on the buttocks with some pretty intense itch, and that's another area where we can have irritated hair follicles that get inflamed and develop what we call folliculitis, small red bumps and pustules that develop on that area too. So that's another thing to think about. Another condition that is something we often need to separate with DH is a rare condition called linear IgA bullous dermatosis. In adults, this is often caused by drugs and can often present as larger, more widespread blisters. So not just in these clusters in the typical DH areas that we see. There's some treatment similarities between DH and linear IgA bullous dermatosis, but linear IgA won't have the particular need for a gluten-free diet. So that's another important way to tell them apart. So in all these conditions, we're thinking, okay, I just listed, 5 out of many that when you come in with an itchy rash that it could be. Well, then how do we make that particular diagnosis? If a person is coming in already with known celiac disease or has already had positive antibody testing and is presenting with a pretty classic rash for DH, it makes it a little bit easy for us in that we might not have to do a skin biopsy. We can just, agree and say that this clinically, this looks like DH. If it's not such a cut and dry case, and as I mentioned, it's the minority of patients that are going to come in with gastrointestinal symptoms as well as skin signs of celiac disease, that often in dermatology we think about doing a skin biopsy. This is a relatively short procedure that can be done in your dermatologist's office. We only need to use local anesthesia, so injecting like you have when you go to the dentist, injecting some lidocaine into the area of the skin. We use this small tool here and call it a punch to take a small 3 to 4 millimeter sample and then close the area with a small stitch. Sometimes you can also, in addition to using the shot of lidocaine, you can use some numbing medicine on the skin prior to this to make it easier. And most folks are able to tolerate this. Again, I'm doing these biopsies for a variety of different conditions on to, very young children. It's a little bit uncomfortable, but there's not too much pain afterwards. So most people are able to do this. Ideally, to diagnose dermatitis herpetiformis, we would need 2 separate skin samples because we're looking for 2 different things. We're processing that tissue in 2 ways under the skin. One would be from a blister area. The newer, the better for doing this. And another would want to be from adjacent, somewhat normal appearing skin for this. And like other testing that we have done that we're doing for celiac disease, you want to do these biopsies while the child or the patient is consuming gluten. So we don't have a false negative from this. As I mentioned before, these are stitches that the wound is closed with stitches. They're just on the top. In my office, we don't use dissolving ones, and they typically come out in 1 to 2 weeks. One of the things is just as in general for celiac, and anytime you have a biopsy from the skin, it's important to remember biopsies can also be very helpful, and they can sometimes give us, a very clear understanding. Okay, this is what's going on in the skin. Sometimes it matches up well. What we see under the microscope matches up well with what we see clinically, and it's very helpful. Sometimes, depending on how active the inflammation is at that particular site, and for a variety of other factors, they can be nonspecific. And I just always want to mention this in case someone has had a biopsy done at a previous site, and was initially maybe given sort of a confusing report. There's always a possibility that that biopsy can have a second read, that you could ask someone else to reread it, like at another hospital, or have it sent off to another dermatopathologist. I just offer that because a lot of the reading of skin biopsies is somewhat subjective to who's reading it and to sort of their understanding what exactly they're looking for, how much of the biopsy they look at. And so it's always something to think about. If you've had a biopsy and are still having some concerns about it, being able to advocate and ask for a second opinion is always something that you can do as a patient. Sometimes do need to rebiopsy and things like that to try to get an answer, but that's something I just want to make sure that people are aware of that they can do. So what are we looking at when we take these samples of skin and look at it under the microscope? Our dermatopathologist are looking at it. So here, this bright pink one there on the left is what we see when we look under the microscope and we're just staining for different parts of the skin. Like up here under that word microscope, that's the very top of the skin where you can see the protective layers there. And then down here, we come into the dermis, and here is where you're seeing the active areas of DH. You're seeing those inflammatory cells, lots of neutrophils, the type of white blood cell that's attracted to these areas. You're seeing them start to form these small vesicles under the skin. You can see that there's extra fluid there, and this is where the inflammation is taking place. So I mentioned that in DH, we often do 2 biopsies, one to get sort of this overall appearance of the skin, see where the inflammatory, the white blood cells are, and then another to look at where different antibodies are coming along the skin. This is similar when someone is doing blood work, looking for that tissue transglutaminase 2 and seeing if someone has a positive result on that. We're here looking for IgA, a type of an antibody, and how it appears in these areas, this dermal papillae that you can see here. And you can see here that it's in relatively clumps of areas. So you can see these large conglomerations where you can see this activity here, the inflammation. And that's important for thinking about, this is called immunofluorescence, to think about this because Dermatitis herpetiformis has these lumpy clumps of IgA under immunofluorescence, where one of the mimickers I was talking about, the linear IgA, bullous dermatosis, that is more of a smooth line of IgA. So you'd see a bright green undulating line just sort of tracing out those hills and valley of the junction between the dermis and the epidermis. So thinking about treatments for DH, once you've gotten it diagnosed under biopsy, that the gluten-free diet is key. It's going to take many months for these lesions to improve, for that inflammation in the skin to retract. That often the skin can be much slower to respond than the GI symptoms. For treatments for GH, we can think about doing topical corticosteroids, topical dapsone. Our go-to for it, though, is oral dapsone. Typically, we look for a type of enzyme level, G6PD, that if someone has lower than normal levels, we get concerned about using dapsone. So we might, depending on ethnic background, those might be done, that tests might be done ahead of time. There's monitoring blood work that needs to be done with dapsone. Dapsone, just by its basic mechanism, can stress out red blood cells. And when we stress out red blood cells, they don't tend to stick around as long, and that can lead to anemia. It can also lead to a condition called methemoglobinemia, which is a decreased oxygen which is a type of hemoglobin that doesn't carry oxygen quite as well as normal hemoglobin. And if we're not able to carry the oxygen load that we need, sometimes we can get headaches, fatigue. Sometimes it can present like blue skin in lips in like significant cases. Again, that's not common, and we do monitoring blood work while someone is on dapsone more at the beginning, and then as you're on it for months and months, that spaces out over time. In addition, we'd also want to continue to monitor for the additional skin conditions that are associated with celiac disease. And I'm just going to go through quickly and show you some of this. So celiac disease and psoriasis typically being a more common skin finding that we see more often than dermatitis herpetiformis. Psoriasis has particular areas that it likes to be. Some of them are very similar to DH in that they both like to be on the back of the elbows, the top of the knees. Psoriasis can also be with thicker plaques on the palms and soles. It also likes the scalp, sometimes the ears, and also around the belly button. Psoriasis looks a little different than DH in that it has flatter pink areas that often are pretty well, we call it demarcated, like you can draw a line around it, say, okay, this is where this plaque of psoriasis is. And often psoriasis does not have those little blisters that come up like DH. Sometimes psoriasis can be itchy, but it's usually not as typically sort of like going out of your skin itchy as DH. And psoriasis in the scalp in this picture here on the left can just look like really bad dandruff there. With celiac disease, you can also have oral ulcers or aphthous ulcers that can be uncomfortable on the lips or the tongue that develop. And just, I was trying to differentiate between like the parts of the body where you can have eczema, atopic dermatitis, and where you can have celiac, but you can have both. And here you can see, we call those flexural areas, the back of the knees or the crooks of the elbow, red, scaly, itchy rash. So again, pretty similar to DH, and you can be dealing with both of them at the same time. Some more pictures here, it looks very similar. You have little small bumps in the lower back coming into the buttocks that are pretty itchy. And that this could be pretty hard to tell this apart from celiac disease on the skin. So it's something, again, really needing to work with a dermatologist, considering biopsy and putting that together with lab work that's been done to make the difference. Channi will definitely be going more into celiac disease and acne. Celiac disease, you think about just general inflammation that we can see acne being triggered as well. Interestingly enough, we also use topical dapsone as a topical acne treatment. So it's something that we could think about doing in this case as well. Again, acne itself is pretty common, and we have a lot of other ways to treat it as well, but just think about that. So I just want to say my quick little takeaways, and you can think about DH again, intensely itchy blisters on extensor knees, elbows, and back. Again, you can also have other rashes. You can have those crusting the scabs. You can have things that look like hives or just red rashes, typically responding to the gluten-free diet over a period of months, and unfortunately responding to oral dapsone within days. We can confirm it on the skin biopsy, and if you've had a skin biopsy before, always think about the potential of like a second read. It's something I also think about, more for kids, not wanting to put someone through a second biopsy, but that's always the potential. And as Channi will mention in her talk coming up, thinking that just as someone's having celiac, it's not meaning you can also have a lot of the other, you can have just more run-of-the-mill skin conditions, some you might be more predisposed to, like eczema, atopic dermatitis, psoriasis, oral ulcers. So it's really important to try to have a close follow-up with a dermatologist, whether someone who has a specialty in GI skin concerns, but just someone that you feel comfortable with, and you can feel comfortable going back to and talking about the different concerns as things come up. So I think I'll turn it back now to Dr. Fasano. Thank you.
Thank you so much, Dr. Sophie. This was, a great overview, great way to start. And again, I want to remind everybody that we have a question and answer, feature there. I see some questions coming in. Again, please make this as general as possible. It is now my pleasure to introduce our next speaker, Dr. Kourosh. She's an MD, MTH, and board-certified dermatologist at Massachusetts General Hospital, and is the Assistant Professor of Dermatology at Harvard Medical School. She's very much committed to patients' advocacy and solving public health problems for patients with skin disease. Dr. Kourosh developed the Skin Advocate iPhone app, a free iPhone application that connects patients with a patient advocate organization for their skin conditions. She serves as Director of Community Health in MGH Department of Dermatology, providing access to dermatologic care for underserved communities. She's the founding director of the Clinic for Pigmentary Disorders at MGH, and founder and director of a very interesting project called Project Phoenix, MGH's pro bono tattoo removal program, assisting individuals escaping gangs and human trafficking. She also advocates for patients at the national level in the American Academy of Dermatology delegation to Congress to protect medical research and affordable care for patients with skin disease. She has received numerous awards, including being named one of the Medscape's 25 Rising Stars in Medicine. So again, without any further ado, let me give the floor to Dr. Kourosh.
Thank you very much, Dr. Fasano, for this very gracious introduction. On behalf of our entire team at Massachusetts General Hospital and Harvard Medical School, we are delighted to be here speaking with you. As Dr. Fasano mentioned, my roots in my dermatology and medical education are deeply intertwined with patient advocacy. I've worked with patient advocacy groups since I was in my training, the groups for skin disease, and I'm delighted to be speaking with you in the Celiac Association. As he mentioned, my research team has also been very dedicated to patient advocacy. We've published several books to help patients with skin conditions live successfully with their diseases, which will be highlighting some of the information from those books, such as Facing Psoriasis. Without further ado, I'd like to introduce our clinical and research fellow, Channi Silence. Channi is a graduate of the University of California, San Diego, and attended Tufts Medical School. As a part of her dermatology training, she has joined me and my team at Massachusetts General Hospital to do a one-year clinical and research fellowship in dermatology. And she has done extensive research on the signs of celiac and gluten sensitivity in the skin. And we are delighted to have her present on behalf of our team today. And I will be present to field questions at the end. So without further ado, Channi, please take it away.
Thank you so much, Dr. Kourosh, for that introduction. And thank you to the National Celiac Association and Harvard Medical School Celiac Research Program for having us today. We are really excited to be talking to you about this today. So I will start our presentation now. So the name of our discussion today is Celiac Disease and Your Skin. And we want to start by saying that we have no conflicts of interest to disclose. And as Dr. Delano has said, all of the patient photos used are from educational scientific journals or educational sites, and none of them are patient photos. So just a quick outline of what we'll be discussing today. We will be talking about psoriasis, alopecia areata, eczema, vitiligo, secondary causes including nutrient deficiencies, the microbiome, and gluten-free skin products. So we're going to start with a case. Our first case here is a 43-year-old woman who presents with joint pain, present for 2 months, with scaly red patches on her extensor surfaces of her arms. And again, this means like your elbows, or if it was on the legs, on the knees. And this is consistent with psoriasis. 3 months later, this patient presents with worsening anemia, and duodenal biopsies were consistent with celiac disease. After following a gluten-free diet, the patient's blood counts improved, her joint pain resolved, and her skin lesions disappeared. And here's some photos on the right which demonstrate red patches with scale. And then in the bottom right corner, there is one area with an arrow. And what this is showing is the output sign. And what this is when you scrape away your skin and the scale that's there due to the psoriasis, it causes a little bit of pinpoint bleeding. And this is commonly found in patients with psoriasis. So what is psoriasis? This is a chronic, relapsing, inflammatory skin condition that affects about 2% of the general population. And in patients with celiac disease, it's found in about 4%. However, one thing we really wanted to highlight today was that Celiac disease is a spectrum, and even if you do not have celiac disease, having a gluten sensitivity can still predispose you to these conditions. So research has also found that up to 25% of people with a non-celiac gluten sensitivity can still present with psoriasis. So here are additional photos describing what we had mentioned. So psoriasis can present with these large red plaques shown here on the left, and it can also be described as having a silvery scale as seen on the bottom right. Even though it's commonly found in areas of friction, such as your elbows or your knees, it can also be found in diffuse areas such as your back, shown here on the top right. Patients will have dryness, they could have bleeding, like we had mentioned before, and occasionally itching. Psoriasis is also associated with other abnormalities such as nails and joint pains, as described in our case report. So how are psoriasis and celiac disease correlated? Well, there has been some controversy. However, some of the aspects in science that have been found that makes them correlated include psoriasis having increased frequency of IgA anti-gliadin antibodies. And these are commonly found in patients with celiac disease. Patients with celiac disease or non-celiac gluten sensitivity and psoriasis have also been shown to improve their psoriatic symptoms after adopting a gluten-free diet for 3 to 6 months. One study actually had to discontinue their research because the non-gluten-free diet was causing such severe symptoms in their patients. Other mechanisms showing their correlation include that both diseases are associated with intestinal permeability, or what we would call a leaky gut. T cells, which are common immune cells, play a role in both conditions, both psoriasis and celiac disease. And psoriatic lesions are commonly related to vitamin D deficiency, which is commonly found in patients with celiac disease. So what other research has been found that is showing gluten sensitivity as a trigger for psoriasis? Well, one study comparing a gluten-free diet in patients with these elevated antibodies and psoriasis found that the gluten-free diet improved symptoms in 73% of the patients. In addition, 82% of these patients had a reduction in these antibodies. Interestingly enough, though, 50% of the patients, even though they had anti-gliadin antibodies, had normal duodenal biopsies, demonstrating that they didn't have full-on celiac disease, but they were still showing the effects and the cause of gluten in psoriasis and in presenting with these symptoms. So how is psoriasis treated? Well, one of the mainstays of treatment is topicals. So this would include lotions, creams, gels. And here are just a couple examples of what the topicals can include. They can be steroids, they can be vitamin D analogs, they can be immunosuppressive drugs like calcineurin inhibitors, they can come from a jojoba tree, it can be coal tar, salicylic acid, and vitamin A derivatives. In addition to topical treatments, patients can also take oral medications, and they can take injectables called biologics. And both of these reduce the immune response, causing decrease in symptoms of psoriasis. However, many doctors don't want to be providing or don't want to be giving these medications to patients because they can come with significant side effects. So one form of treatment that dermatologists love to use because of its safe side effect profile is actually light therapy. And you may wonder, like, how does light affect psoriasis and why is a dermatologist recommending sunlight? Well, it's actually been found that patients who have about 10 to 15 minutes of sunlight show a decrease in the immune system, reduction in inflammation, reduction in itch, and a slowing of the progression and growth of cells. So what scientists and doctors have now done is they have targeted the specific rays in the sunlight called UVB rays, and they've converted these into machines that almost look like tanning beds, as shown on the left, where a patient can stand in it with their eyes covered and get these UVB rays. And then shown on the right is a more targeted form where you can just have specific areas such as your hands or your feet receive this treatment to improve the symptoms of psoriasis. So psoriasis is a result of multiple factors, including dysregulation of the immune system, genetics, and environmental factors. So outside of just the medical treatment that we've discussed, such as topicals, orals, biologics, sunlight, there are other modifiable risks that patients can do to reduce their risk of psoriasis. And those include diet, such as gluten-free diet, vegan, paleo, or Mediterranean diets, exercise, reducing stress, and eliminating tobacco and alcohol. And we're going to discuss this more right now. So as we had mentioned before, a gluten-free diet in patients with celiac disease or non-celiac gluten sensitivity can greatly improve the symptoms of patients. It was noted to be about 70–80% in patients. However, if you don't have these symptoms or don't have celiac disease or non-celiac gluten sensitivity, other diets can also improve the symptoms of psoriasis, including a vegan diet, paleo, and Mediterranean. And what do these three diets have in common? Well, they all lead to weight reduction, reducing the risk of diabetes and cardiovascular disease. And why, again, does that matter? Well, it's been shown that obesity correlates with worsening psoriatic symptoms. So a low-calorie diet has shown to reduce psoriasis severity significantly. Obesity leads to pro-inflammatory factors. Weight can affect your treatment efficacy. So, these oral medications or these injectables that we were possibly giving to patients with psoriasis, if you have increased weight, they don't work as effectively. And obesity is a risk for psoriatic arthritis or joint pains. Now, outside of diet, exercise, same idea, right? If you're reducing your weight, if you're reducing your BMI, if you're reducing your waist circumference, you're going to improve your risk of psoriasis. However, there was a study that showed patients who just did diet and patients who did diet and exercise. And what they found was that moderate exercise reduced the psoriasis by 20–30% more. A third modifiable risk outside of diet and exercise includes stress. And obviously, this is much easier said than done, but 88% of people state stress as a trigger for psoriasis. And stress is likely to reduce the efficacy of treatments. Cortisol, which is the hormone for stress, was found in higher levels in the salivary samples of people with psoriasis, possibly highlighting how stress and psoriasis are related. And then our fourth modifiable risk is tobacco and alcohol. Both of these substances increase inflammation in the body and are associated with worsening symptoms. Thus, eliminating these two will significantly decrease your risk of psoriasis. So now that we've talked at length about psoriasis, I do want to move on to some other conditions possibly associated with celiac disease. So our second case here is a gentleman, a 38-year-old man, who presents with a history of alopecia areata universalis since he was 18 months old, so since he was a little baby. No history of diarrhea or weight loss, and after presenting with recurrent canker sores, he was tested for anti-gliadin antibodies, which came back positive. Nutrition and blood counts were all normal. However, biopsy showed subtotal villus atrophy, so that's just a fancy way of saying that he was positive for celiac disease. Now, when looking at this case, there are a couple components that I really want to highlight, and that includes the alopecia areata universalis. So this is complete hair loss, right? It's not just patchy hair loss, but this patient has lost hair completely at a very young age. In addition, this patient had almost no symptoms of celiac disease. He has no diarrhea, no weight loss, no nutrient deficiencies. However, he was still positive for celiac disease, showing that his only symptom in this case was his hair loss. So alopecia areata is an autoimmune condition presenting with non-scarring hair loss. It occurs in about 4% of the general population and typically occurs in patients 20 to 40 years old. In patients with celiac disease, it's been shown to be in about 1 in 85 people. So again, you could have complete hair loss like the universalis, or you can have this patchy hair loss as shown in the photos on the left. So there are only a few cases presented in the literature. However, when they do occur, they tend to be more severe, so complete hair loss. And it is sometimes the only clinical presentation of celiac disease, as stated in our case report or case study. Gluten-free diets were documented to cause complete remission of the hair loss in 3 patients adhering to a gluten-free diet, showing that there could be this correlation between the hair loss and celiac disease or gluten sensitivity. Eczema is another condition that I know a lot of patients have had questions about. And as Dr. Delano had mentioned, this is very, very common in children. About 15 to 20% of children are affected. And in a study in 2004, it showed that patients with celiac disease were 3 times more likely to be affected by this. However, a more recent study with over 100,000 patients saw that the prevalence was more like twice as much in the general population compared to the general population. So one study did look at patients not with celiac disease, but with non-celiac gluten sensitivity and signs of eczema with severe itching and skin lesions. And they found that there was a disappearance of the disease after about 1 month of initiating a gluten-free diet. Again, just like psoriasis, even if you don't have celiac disease, but you have this gluten sensitivity, you may be experiencing these symptoms. In a separate study, 80% of patients saw improvement of their eczema with a hypoallergenic diet, which included eliminating gluten. And then the last condition I'll be discussing in this section is vitiligo. So vitiligo is an autoimmune condition where the immune system attacks the pigment-producing cells, and this leads to loss of function. So as you see here on the left, this patient has complete loss of pigment on the knuckles of their hands and the dorsal aspects. Vitiligo is commonly associated with other autoimmune conditions such as hypothyroidism and diabetes. However, there has been case reports documenting vitiligo and celiac disease and repigmentation, meaning the pigment came back after adhering to a gluten-free diet. So now that we've talked about psoriasis, hair loss or alopecia, eczema, and vitiligo, I do want to move into some of the skin signs associated with nutrient deficiencies, because this can commonly be found in patients with celiac disease. B12 deficiency is reported in as high as 41% of patients with celiac disease. It's improved when patients follow a gluten-free diet, and some of the common dermatologic presentations include hyperpigmentation, as shown in the hands on the top left, where you get this darkening in the creases. You can get glossitis, which is inflammation of the tongue. So I couldn't find a good photo of it, but sometimes you can get this big, red, beefy tongue. And then you can also get a type of glossitis called atrophic glossitis, where you lose the papillae, which is the little pinpoint features on the tongue, and it becomes smooth. Another presentation of B12 deficiency is angular stomatitis. This, again, is just a fancy term for saying inflammation on the corners of the mouth, as shown on the bottom left. Aside from B12 deficiency, iron deficiency or anemia is a common presentation found in undiagnosed celiac disease. And the literature states it could be anywhere from 3 to 40% of patients. So it's very, very common. One study also showed that non-celiac gluten sensitivity was patients with non-celiac gluten sensitivity had anemia in about 22% of patients. So what are causes of iron deficiency in celiac disease? Well, you get reduced absorption of nutrients due to inflammation in the gut. You get increased blood loss from this inflammation, and you get intravascular hemolysis, which is basically when your red blood cells start to break down. Common presentations of iron deficiency anemia include skin thinning, dryness, itching, hair loss, atrophic glossitis, which is the inflammation we had discussed about the tongue, and koilonychia, which is a depression of the nail plates. Aside from B12 and iron deficiency, other common presentations of nutrient deficiencies include zinc, vitamin A, and niacin, which all lead to a form of dermatitis, which is inflammation of the skin. Unfortunately, I wasn't able to find a photo for a zinc dermatitis. However, zinc deficiency was found in up to 60% of patients with with celiac disease. And it basically leads to a very scaly red rash, sometimes found around the mouth and also in the buttock area. Vitamin A deficiency can lead to a condition called pityriasis rubra-pilaris, which is noted here on the top right, which is this diffuse redness on the belly. And then niacin deficiency, which is a B3 deficiency, can lead to a condition called pellagra, which also forms a very severe dermatitis, as noted here with this patient along his neck and also on his hands. So other non-specific symptoms that can be found with vitamin deficiencies include dry skin, easy bruising, mouth ulcers, brittle nails, and hair thinning. And again, these symptoms can occur in lots of diseases, but they also can occur in celiac disease due to the inflammation in the gut. So another topic we wanted to discuss today was the microbiome, because this is a hot topic in medicine, a hot topic in research. Patients want to know more about it. There's so much about it in the news and in the media. So we really wanted to touch on it today to at least give you some resources and understanding behind it. So the normal gut microbiome plays a vital role in intestinal homeostasis and health. And what research is finding is that there are good bacteria that live within our gut and within our skin that are protecting us from certain conditions. So when there is a dysregulation of this microbiome, or a term called dysbiosis, it can lead to pathologies or disease. The main thing that I want to reiterate with dysbiosis is that what this means is a reduction in microbial diversity and a loss of beneficial bacteria. Because these two things, the loss of diversity and the loss of beneficial bacteria, are going to come up multiple times throughout this talk as I proceed through the different conditions. So celiac disease is associated with significant microbiome alterations. Studies have found increase in gram-negative bacteria, decrease in gram-positive bacteria, and a possible restoration of this with a gluten-free diet. Also, a recent study from the Mass General Hospital for Children noted differences in the microbiome of breast milk in mothers with celiac disease, possibly highlighting how celiac disease is not only affecting the microbiome of the mother, but also of their children. So what conditions have been implicated in this dysregulation of the microbiome? Well, here are a few that we found in the literature, which include acne, eczema, psoriasis, hidradenitis, rosacea, seborrheic dermatitis, alopecia or hair loss, skin cancer, and wound healing. Unfortunately, I won't be able to talk about all of these today, but I do want to talk about the most common ones that we see in clinic. So acne, as Dr. Delano had mentioned, this is a very common condition affecting many adolescents and adults. And in relation to the microbiome, Bacteroides, which is a species found in the gut, has been implicated in cases of acne since the 1950s. And this specific type of bacteria increases with stress and is associated with a Western diet. In addition, acne patients have showed lower gut microbiome diversity. So this is a form of dysbiosis that we have discussed. In addition, their skin microbiome has been linked to certain strains of C. acnes. C. acnes is the main bacterial component, or main bacteria that has been associated with acne. And what this dysregulation and the abundance of certain strains presents with increased sebum production, so that's the oils found on the skin, and increased immune stimulation, which leads to the inflammation that we see, the redness, the pain that patients sometimes have with their acne. Other studies have shown, one study that I found actually was 453 patients noted a significant difference in their acne in patients with a vitamin D deficiency and patients with tissue transglutaminase antibodies. So these are both the positive antibodies and the vitamin D deficiency can be associated with celiac disease, and there was a difference in the acne prevalence. Another study found, just a small difference, but patients with celiac disease were about 1.4% and the control was 1%. So again, acne is kind of one of those conditions that isn't like super correlated with celiac disease, but I know this was brought up in questions and that people are very interested in this. However, other diets that have been implicated in acne instead of the gluten-free diet include sugar, dairy, and fats. So I feel like this is a booming field that's definitely going to be researched more, and people are going to be interested to see how both the microbiome, celiac disease, and our dietary intake are affecting this condition. Another condition outside of acne that may be affected by the microbiome includes eczema. So this is closely linked to gut microorganisms. Because this is a condition that's commonly found in children, what researchers have found is that the mode of delivery, whether you're a vaginal delivery or a C-section, the mode of feeding, whether it's breast milk or bottle feeding, interaction with others, the use of antibiotics, have all been shown to affect both the biodiversity, so the types of bacteria that are found in the gut, and the maturation of the immune system. And patients with eczema tend to have a low biodiversity, and which leads to a pro-inflammatory state. Psoriasis is another condition that's found like this. So 10 articles have shown that there's been a dysregulation of the microbiome in patients with psoriasis. However, the studies have a lot of heterogeneity, meaning that they aren't completely consistent. However, there's still a lot to learn and really exciting research coming out of this. So outside of just the gut microbiome, the skin microbiome can also cause dysfunction and can potentially predispose patients to disease. So Staph aureus, which is commonly found on the skin, has been implicated in conditions like eczema and psoriasis. Their higher concentration leads to more inflammation, and Staph aureus leads to a decreased concentration of the good bacteria. So when we're exploring new treatments, oral probiotics are something that people have looked into in regulating this dysfunction in the microbiome. So what are probiotics? Well, these are the ingestion of good bacteria, and this is commonly found in products like yogurts or fermented drinks like kombucha. And what research has found is that probiotics can improve acne, and it improves the tolerance of medications such as antibiotics, which are frequently used to treat acne. In eczema patients in utero, they gave mothers probiotics, so while the child was still in the womb, and this actually led to decreased development in eczema in these children. And then in psoriasis, they've done mice studies which have shown that probiotics reduces the inflammation in the scaly lesions in mice. However, again, all of this is very preliminary. A lot of more research needs to be done, but it's going to be very exciting to see what happens. I do have to move a little bit more quickly since we are reaching the end of our discussion. However, skin probiotics have also been discussed, and I did want to include this because it's extremely interesting, but a fecal transplant, which is not used for any of these skin conditions. However, a patient with C. diff infection received a fecal transplant, and it actually led to the regrowth of their hair, possibly highlighting how the microbiome affects these conditions. Here's just a list of some natural products or herbal medicines that patients sometimes may have questions about. And although, again, promising, and there have been studies where people have improved with these medications and treatments, there's still limited research and a lot more to be studied. So I just want to finish real quickly and state that product awareness is really critical for patients with celiac disease and non-celiac gluten sensitivity, because some products can have gluten in them that we would never suspect, including medications, vitamins, or supplements. So I listed here just some common things that you would want to look for in those ingredients. And lastly, I just wanted to touch on gluten-free skincare, because I'm sure people have questions about this. Right now, scientific evidence does not prove that cosmetic treatment or products are harmful to individuals with celiac disease. And this is primarily because gliadin, which is the component that you have the immune reaction to, cannot be absorbed through the skin due to its large size. However, there have been case reports and documented information stating that if you have a product that's on the hands that you may consume while eating, or if you have large skin abrasions that products could potentially absorb through, or if you are using a product such as a lipstick, which is around the mouth that may cause ingestion, this could potentially lead to symptoms. However, it's such a low concentration that it's very unlikely. So here's just some resources that we wanted to provide for patients to look up additional information. And I just want to thank you all for joining our talk today and listening, and I appreciate your participation.
Wonderful. Thank you, Channi. Really appreciate it. There was very exhaustive, coverage of the spectrum of skin lesions and celiac disease and gluten-related disorders. Now, we have 15 minutes for questions and answers. We have a wealth of questions that I would like to go through as much as we can. So we will try to address as many as we possibly can. And what we'll do, we'll divide this in 3 groups, let's put this way, in which we will start with Dr. Sophie that will address, the dermatitis herpetiformis questions, and then we'll have Channi to do, psoriasis and acne, and then the rest will be mixed. We will have the 3 panelists to go through all this. So, Dr. Sophie, this is for you, related to dermatitis herpetiformis. How frequently do you see DH on the toes?
It's not one of the more frequent areas that we see. And again, the toes are different components. So if you're thinking of like the underside of the toes, the more plantar surfaces, it could be more of like the red areas, the small bruises versus on the top, it could potentially be more like the small little blisters, but it's not the most common area. There are other things that can be pretty itchy and blistering on the toes. Like I would think like an allergy, eczema, some scale that we can see more in teenagers. So that would probably be my first concern that I would think about before DH.
Great. So other than gluten, there is any cross-reactive foods that can exacerbate DH?
There is known taking foods, if you're doing like topical iodine, can be irritating to the skin, but that's sort of like the main one that I think about.
Why is so hard to get the correct diagnosis for DH? A lot of people, they spend the time to go from one dermatologist to another until eventually will be diagnosed.
I think it's just because, in dermatology, a lot of our skin rashes are pretty itchy. And again, like I mentioned before, like whether someone's going to be thinking about like the less common conditions like DH, or if their mindset is more sort of like eczema. I see a young kid with an itchy rash, my mind's going to go to eczema first. So I think that is why that it can take a while. I mean, I think in dermatology, a lot of things, the more exotic, can take a while to find out. So it's really important of trying to find someone that you feel comfortable with, that you want to work with, that you want to go back to, because having to, every time you have to go and present your history again and to like do a different like workup, it can make it a longer process. So just trying to find someone that you feel is really going to go that journey with you, and think about doing things like biopsying, doing the blood work and things like that. But can just be frustrating. One of the frustrating conditions that we have.
That's right. And correlate to that, is there any other way to diagnose DH outside of the painful biopsy?
Yes. So I definitely think, as I mentioned before, if you're one of the minority, the 16 to 20% of patients that are coming in with the GI symptoms that have possibly had, positive antibody blood work testing before, then again, we don't have to necessarily do the biopsy, that we can make the diagnosis, we call it clinically. And again, also, I just think coming from the clinical perspective where I do biopsies on small children, I think it can be made less painful, doing things like taking Tylenol beforehand, doing the numbing creams. Sometimes we even do like distraction techniques on the skin where a small little vibrating device can distract. So what you really should just feel is the needle going in. And that's it's a hidden, a silver lining a little bit about DH, because if you have it in a lot of different areas, we can try to find a place that might not be as sensitive. Like it's going to hurt more if you do it on your hands and feet versus if you're doing it on the back of a thigh. So I think working with the clinician, doing the numbing medicines and distraction, we can make it less painful.
How you can distinguish between atopic dermatitis and DH?
Again, that definitely can be difficult. Usually with atopic dermatitis, we're looking at, again, the history of starting in infancy, possible connections with things like asthma, food allergies, seasonal allergies, a family history, and how they're responding to medication, to the topical steroids. Again, DH will respond in part, but eczema, I should be able to get a pretty good clearance with the topical steroids.
That's a tough one because I'm not sure the pertinence of the question, but there's a question says, how you can distinguish between dermatitis herpetiformis and brachial nerve neuropathy? So let me step in. Whatever person asked the question, I believe that he or she was under the impression that this blistery, painful, rash full of nerves like, shingles, but that's not the case, DH. So I'm assuming that it's easy to distinguish, right?
Yes, definitely. And you think about like more of an isolated area, like I expect DH to be on both sides of the body, like not just involving one side of the body, as like the neuropathy is typically in that way.
Right.
It can also be uncomfortable and painful. In the neuropathy, I wouldn't expect the blisters to be developing.
And how do you confirm DH if the only symptoms of celiac is expressed as the skin rash? So how you can say that this is celiac disease?
Sure. Well, again, as mentioned before, that a lot of those patients are coming in just with the skin rash with no background history of GI symptoms, that if you looked in their intestines, they are going to be positive. They do have DH going on. there. And so again, going back to the things like looking at your blood work and doing a biopsy.
So there are several questions about the treatment with dapsone, and again, people, they acknowledge that at the beginning of diagnosis, you need both the gluten-free diet and dapsone and so on and so forth. But some people, they experience that after they stop dapsone, the DH is continue to be controlled. Others, they say they have to go back to dapsone. In other words, the question is, what is the rule here? What are the consequences to be chronically on dapsone?
Right. I mean, I think,
if you need to take this for a long time.
Right. And again, this may be something more, I think, I just don't, again, not having that many chronic patients on it, but I do think of it being a safe medication that you could monitor over time. We're going to continue to be looking at how one's blood counts are doing, how, the liver is functioning with this, but I don't, in my mind, I don't have like an end date with dapsone. And, dapsone, again, is sort of like a quick on and off for the symptoms of GH, where the gluten-free diet is going to take a while. So I would say hopefully one could think about, as the gluten-free diet is kicking in and someone is getting, pretty clear or almost clear, that you could think about decreasing the dapsone. Just putting a little plug there, dapsone is never a medicine that you want to just increase on your own because of those side effects, the stressing of the blood cells, decreased oxygen carrying capacity. Those are related. We know dapsone just does that. That's not like an idiosyncratic thing. That's dapsone doing its job. And so you don't want to go up on the medicine by itself. It's always, you want to do it in conjunction with talking with your physician.
So there's one more question. It says, hives that are recurrent on knees and elbows, they are the typical place where DH manifests, by the way, will raise concern for DH, and if so, what should I do about it?
Hives in general and can be pretty chronic and pretty ongoing. We have many systemic medicines for that. And sometimes we see hives in places of pressure. I would think about potentially, thinking about doing, again, it goes back to doing blood testing and to think about a biopsy to see how that looks under the skin, to see if we see signs of actually, because hives are going to look different than DH under the microscope.
Wonderful.
But and some people they don't have those small little blisters. They do just have hives.
Okay. Let me move now. Thank you very much, Dr. Sophie. I really appreciate it. All right. So now let's move these questions now on psoriasis and acne, and then we go to general questions. We have another, 7 minutes. So again, quick answer to this quick question. Let's start with psoriasis. Is celiac disease related to psoriasis?
I'm happy to respond, Dr. Fasano. Could you please repeat the question? I couldn't hear you very clearly.
Yeah, is celiac disease related to psoriasis?
Yes. So as you saw from Channi's presentation, there is, first of all, yes, celiac disease has been found in psoriasis, but one of the principles that we hope to teach in this presentation is that sometimes the findings on the skin are not a slam dunk diagnosis with the disease. As often, as Dr. Fasano can probably attest, and all the doctors say, sometimes your body doesn't read the textbook. Okay, so we have these classical diseases like dermatitis herpetiformis, which Dr. Delano discussed, which was the classic case of the, textbook skin presentation of celiac disease. But actually, it's relatively rare, as the doctors in our panel are discussing, that everything lines up for the diagnosis, right? So then what do we do when a patient comes to us and says, but doctor, I'm having these symptoms? We start looking and we find that sometimes there are these subclinical presentations. So what we found, in the past 20 years is that there's a gluten-sensitive variant of psoriasis, as Channi's presentation showed us, and that gluten sensitivity can manifest actually in many different ways in the skin. Okay, so sometimes you may not have a clean, clear-cut diagnosis like dermatitis herpetiformis, but you may have psoriasis like many people do, but not realize that it's the gluten that's triggering your psoriasis, or that it's the gluten that's triggering your eczema or your acne. So what we really want to sort of illustrate, and what I really try to educate my patients is, as Channi mentioned in the presentation, our group at Mass General, we have team authored these books called Facing Psoriasis, Facing Eczema, Facing Acne. And we talk about the role of diet and gluten and the research studies that have been found, because a lot of patients don't realize that even before they go to medicine, if they try dietary modification for a few months, they may find that they don't need medicine or that they need less medicine. So we're really trying to raise awareness of the body as, you know, this concept of balance and ecosystem. And as Dr. Fasano is an expert in the microbiome, I'm sure he can attest that, you know, that we in medicine are starting to think about this concept of balance and to treat the patient as a whole person first by modifying the diet and modifying these other factors and see how much better can we make them before we go to drugs, you know, and that's the best way if we can get there. So this is why we want to kind of raise awareness that if you're having skin issues that maybe don't fit into this nice, clean cut, cookie cutter dermatitis herpetiformis, you may have other skin issues which you may not realize are being triggered by your gluten. So we want to sort of educate and raise awareness to look for that.
Yeah. On a partially related note, you already partially answered this, but if I have psoriasis that I know that have been, you know, eventually triggered in the context of celiac disease, and then I'm exposed to gluten, you know, does the consumption of gluten may cause a flare?
Correct. And it's not for everyone, right? So you know, I think in my patients, about 50% of the time, I see the difference in diet. Some people are more responsive to it and some people are not. But considering that the patient only has something to gain and nothing to lose by trying dietary modification. So I tell everyone, go ahead and give it a try for a few months, try gluten elimination and see what happens. And a decent percentage of them get better this way.
Yeah. So you know, I believe that Channi touched upon this already, but, you know, there is a question. What is the latest research on the connection between adult acne and celiac? She was talking about gut permeability, the microbiome, but you want to expand a little bit more on that?
Yes. I mean, I think acne is very multifactorial, obviously, and in different people, there can be different causes. For example, you know, there can be hormonal causes, but sometimes, you know, even that can be affected by diet. For example, with dairy products, especially in this country, some of them, you know, may have hormones from the production of dairy products, like in the US and things like that. So gluten is not the only trigger of acne. So when I have a patient that has acne, I talk to them about multiple dietary factors, which Channi mentioned in her presentation. One of them is gluten. In some people, it's gluten. In some people, it's acne. It's dairy products causing their acne. In some people, it can be a high glycemic diet, like a high sugar content in their diet, which can cause inflammation, but also affect the microbiome. So one of the things that Channi was talking about, for example, is that the foods that we eat cause changes in the balance of the bacteria in the gut. As Dr. Fasano is, I'm sure, an expert in this, right? So there are downstream effects. And then that balance of good bacteria versus bad bacteria in the body can result in a state of inflammation that can then affect the skin. So, you know, sometimes it can be a direct effect, like you see that you eat something and your skin breaks out. But sometimes it's an effect that happens over time, that you're eating a certain way, your microbiome changes, and then your body becomes prone to inflammation. So in this situation of acne, because there are actually multiple factors, I encourage patients to change one thing at a time. You know, because you want to change one variable at a time, right? Because otherwise you don't know which one it was. You know, so I say, okay, first start with gluten. You know,
that's
right. So I say, first start with gluten. Eliminate that for a few months, see how you do. And then if it's not enough, then try eliminating dairy, then try lowering your sugar intake. And then also, you know, probiotics, right? But you have to make sure to do your research on probiotics, ladies and gentlemen, because there's a lot of fake products out there, as I'm sure Dr. Fasano can tell you. So you want to talk to experts like him, right? Because the supplement industry is not regulated by the FDA. So it's very important to bring any product you're thinking about to your doctor and let us read the ingredients and make sure you've got a legitimate one.
So again, I can't agree more. If you have to make a change, do it one at a time. And if you decide to try a gluten-free diet, it's always mandatory, I would say, to test for celiac disease first, because if you start the gluten-free diet and then you don't know if this was related to celiac disease or not a gluten-related disorder, you would not see the biomarkers positive anymore if you start the diet before it's screening. I have time for a very last question. Quick answer. My teenage daughter with celiac disease had bad acne for 3 years, and we tried everything under the sun. It didn't resolve until she was diagnosed with celiac disease, and then the acne was gone. Could the acne have been caused by untreated celiac disease?
You know, I would say that the answer to that could be yes, but it's sort of complicated in that there could be many different mechanisms by which her diet was causing her acne. But yes, we know that gluten could be a trigger, making her celiac disease worse, also making her skin worse. Also, it could be affecting her microbiome, which could be making her skin worse. So anyway, I congratulate your family, and I'm glad that you figured that out and were able to help her through dietary modification.
And on that positive note, I really want to thank very much, our panelists. This has been a lively, extremely interesting, I hope very informative for everybody, webinar that's been followed by more than 200 people. So thank you again. And let me, move back the baton to Lee that will wrap it up today's webinar. Lee?
Thank you, Alessio. Appreciate it. My mind is blown from all the things you mentioned today. Wow, you guys are really wonderful. Thank you. I hope you all found today's information useful. As we mentioned before, a recording of today's webinar will be on the NCA website. Meanwhile, stay tuned for our next program on Wednesday, November 17th, called Holiday Favorites, Cooking Gluten-Free, Beginnings and Endings. We're featuring a holiday cooking demonstration of gluten-free alternatives for tasty and nutritious appetizers and desserts. I'll be joined by Chef Denise Herrera, Vice President of Burton's Grill. Chef Herrera has been with Burton's Grill since the company opens its first restaurant in 2004. Since that time, Chef Denise has developed an extensive gluten-free and allergy-friendly menu with mindful decision-making and team training to ensure safe dining experiences for all. How nice that is. You can check the NCA website for all these webinars, and please consider a donation to Feeding Gluten-Free initiative. This will help so many people in our gluten-free community. Until then, stay well, have a happy and healthy Halloween. Bye-bye.